Have you ever wondered why a doctor will give a patient a tiny 5 milligram pill of a medication to swallow at home, but if that same patient enters the emergency department, they might receive an intravenous injection of that exact same drug, but at a much lower dose? This clinical decision is governed entirely by two foundational pillars of pharmacokinetics: drug absorption and bioavailability. Absorption is the physical movement of a drug from its site of administration into the systemic bloodstream. Unless a drug is injected directly into a vein, it must cross cellular membranes to reach the blood. Most drugs accomplish this through passive diffusion, which means they must be small and fat soluble or lipophilic to slip through the lipid bilayer of cell membranes. However, this process is heavily dictated by the drug's chemical nature and the local environment. Most drugs are either weak acids or weak bases, meaning they exist in an equilibrium between a charged, ionized form and an uncharged, unionized form. Only the uncharged form can easily cross fat filled membranes. Therefore, a weakly acidic drug like aspirin remains uncharged in the highly acidic environment of the stomach, allowing it to be absorbed rapidly there, whereas a weakly basic drug will remain uncharged and absorbed better in the alkaline environment of the intestines. Once a drug is absorbed from the gastrointestinal tract, it faces a massive anatomical hurdle known as bioavailability, which is written as the letter F. Bioavailability is defined as the fraction or percentage of an administered drug dose that reaches the systemic circulation completely unchanged. When you give a drug intravenously, its bioavailability is automatically 100% or an F value of 1. But when a patient swallows a pill, its bioavailability is always less than 100% due to incomplete absorption and a ruthless physiological gauntlet called the first pass effect. After crossing the intestinal wall, the absorbed drug does not go straight to the rest of the body. Instead, it enters the portal vein and goes directly to the liver. The liver acts like a metabolic border patrol, immediately chewing up and destroying a massive percentage of the drug before it ever has a chance to reach the heart and systemic blood vessels. For example, if you swallow a pill of the beta blocker propranolol, the liver destroys roughly 75% of it on its very first pass, leaving a bioavailability of only 25%. This first pass metabolism is exactly why nitroglycerin cannot be swallowed to treat chest pain. The liver would destroy it completely, so it must be given sublingually under the tongue to bypass the portal vein entirely and absorb directly into the superior vena cava. On a classic exam chart, if you plot plasma concentration over time, you can visually calculate bioavailability by comparing the total area under the curve, or AUC, of an oral dose against the AUC of an intravenous dose using the formula oral AUC divided by intravenous AUC multiplied by 100. Beyond the first pass effect, bioavailability can be severely reduced by a patient's individual physiology, such as rapid gastric emptying or malabsorption syndromes like Crohn's disease, as well as physical interactions in the gut, such as taking a tetracycline antibiotic with milk or antacids, where the calcium binds or chelates the drug molecule, locking it up and stopping absorption entirely. Understanding how a drug gets absorbed, how the environment alters its ionization, and how the liver's first pass effect cuts down its bioavailability is exactly how clinicians determine whether a patient needs an oral pill or an intravenous line. Master the relationship between the gut, the liver, and the bloodstream, and you master drug delivery. If you liked the video, subscribe to my channel and I'll see you in the next video.